Hello, this is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today. This is Regenerative Medicine for arthritis, tendinitis, injuries, and back pain. As I go through things, if you have questions, please shoot them into the chat section. And I will, every couple minutes or so, try to pause and answer questions. If you're having any difficulty hearing, please let me know, or any difficulty seeing the slides, please let me know. And you'll have a chance to rewatch a webinar if interested afterwards. And if you have any questions, not only can I try to answer them as we're going through, but you can also shoot us an email afterwards, and certainly we'll try to answer as I'm going along. So what will you get from this webinar? This is really meant to be a high-level overview of regenerative medicine. And what you'll get is you'll learn more about best available treatments for arthritis and tendinitis that do not require surgery, including regenerative medicine treatments, what is legitimate and non-legitimate in the field of regenerative medicine, and how to go about to find the right physicians and clinics for regenerative medicine in terms of finding good practitioners to help you out. So, big question. What would you do if the pain that you're living with was controlled? How would your life improve? What exercise or activities would you restart? And what activities with family and friends would you be able to participate in? So briefly, who am I? Again, my name is Siddharth Dambar, physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections, in practice since 2008. Been involved in regenerative medicine since 2008 as well, and part of the Regenix Network since 2012. The Regenix Network is the largest affiliated group of physicians who are involved in regenerative medicine in the world. So my personal journey into regenerative medicine, essentially, I had a mild shoulder injury from playing tennis, and I started learning about diagnostic musculoskeletal ultrasound in around 2007, 2006. And part of that process was learning about my own shoulder, the biomechanics, seeing it live and real time in terms of pathology, and coming to realize that non-surgically, the treatment options for tendon and ligament injuries, if you've already done physical therapy, are very limited. And progressively realizing that there's sort of this new world of regenerative medicine, of treatments that are available to help out non-surgically with people that have various musculoskeletal injuries. The traditional approach to injuries or pain is very limited, and that's regardless of whether you have tendinitis or a tendon tear, sprains and strains, arthritis and chronic joint pains, or if you've got back and neck pains. The traditional approach are treatments that help to mask the pain and then eventually waiting for surgery, which is really a terrible way to approach things because it's really not a very holistic or low risk approach, and really a terrible approach to humans in that you're really just getting people to live with pain long term, which is terrible. Problems with traditional care: pain medications, they don't fix the problem. They have a lot of side effects. A lot of the anti-inflammatory medications that people chronically use include risks of chronic damage to kidney, stomach, liver, heart, and even bleeding issues. Chronic pain medications in terms of narcotic pain medications have their own kind of side effects that we all know very well now, including chronic opioid dependence. Traditional injections that are utilized, steroid injections, can be helpful. They're typically more short-term. They do have the risk, if you're using them repetitively, of damaging tissue, infection, diabetes, and osteoporosis. And the traditional nerve blocks and radiofrequency ablation treatments that are used can also help with pain relief, but they do have the risk of nerve damage and muscle weakness. And so very important to have other treatment options that don't have those kind of side effects. Other problems with traditional care, there's certainly a role for surgery for more advanced or really sort of bad situations. But if you're using surgery for lesser situations, you're taking at higher risk for issues that don't necessarily require that. The risks of surgery include higher risk of bleeding, infection, tissue damage. There's risk of general anesthesia and obviously cardiac risks as well. A lot of surgeries that have previously been done for things like, let's say, lesser issues, let's say arthroscopy for knee arthritis, have been shown to actually accelerate the process of arthritis and not to be any better than just physical therapy or conservative care. And that's partly because they actually lead to more instability, which can then lead to more problems in terms of arthritis. In addition, a lot of routine surgeries that have previously been done, including knee arthroscopy for arthritis, have not shown to be any better than just physical therapy. And really 80% of musculoskeletal conditions can avoid surgery, but do typically need more than just physical therapy. So searching for better options for myself, for patients, I really started looking for treatment options that had really avoiding some of those side effects that I just mentioned for traditional care, that were still low risk, but could actually treat the cause of people's problems and give longer lasting results than what we were able to do with other traditional care options. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So at Chicago Arthritis and Regenerative Medicine, our approach is focus on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain, really with an approach that involves evaluating for inflammation, instability, asymmetry, neuromuscular issues in every patient, starting with correcting with low-risk interventions, whether that's exercise and supplements, and if not working, then escalating to other treatment options. If your issues are more osteoarthritis, tendinitis, back pain, or injuries related, then utilizing regenerative medicine. In particular, using the highest quality products, which I'll talk about, and a plan that is specifically tailored for your condition, and delivery of cells using the highest level of image guidance. So what is regenerative medicine? Regenerative medicine is the process of utilizing your own body cells to treat arthritis, tendinitis, injuries, and back pain. It involves a normal healing process. So the normal healing process, if you think about it, let's say you have a small cut to your finger. The normal healing process is that you have an infiltration of platelets. Those platelets have growth factors that help to stimulate the local normal healing process by stimulating the local stem cells. That leads to initially inflammation and then a cellular repair process that leads to eventually tissue repair and healing of that injury. So tissues that have poor blood flow don't heal very well with this kind of process. That includes tendon, cartilage, ligaments, discs, labrum, and meniscus. And so regenerative medicine is the process of taking those same cells, platelets and bone marrow, and stem cells, and injecting those cells to coordinate that normal healing process into tissue that has been damaged in order to help expedite that recovery process. So why regenerative medicine? Number one, it treats the source of the problem. It's safer than surgery. It's effective for many musculoskeletal conditions. And again, for those of us who are involved in this process, our feeling is that in the same way that lower risk treatment options for cardiac health and other types of medical issues have replaced traditional surgery, that 80% of traditional orthopedic surgery should eventually be managed by regenerative medicine processes. How does regenerative medicine work? Few different ways, right? We are trying to optimize that normal cellular healing process. So if you take tissues that have been chronically damaged, we can help to assist in that cellular healing process for either joints or tendons. That process ends up leading to a joint or tendon that is intrinsically in itself no longer has chronic inflammation, and the normal proteins or enzymes that you see in a healthy joint or tendon that are no longer there in an unhealthy joint, you're able to get that same sort of enzymatic and proteins that you see in a healthy joint now. By adding stem cells into a tissue that's been damaged or overwhelmed or worn out, you're able to add in the kind of cells that are normally there, meant to help to repair or expedite or optimize the joint health. In addition, by improving the strength and stability of supporting ligaments, which we'll talk about in a bit, whether those are ligaments, tendons, other soft tissue structures, you're actually able to help strengthen the supportive structures to give a more stable joint, which then leads to reduction in pain and better function as well. How does regenerative medicine work? It works in a few different ways. Again, you can also help by reducing chronic inflammation. In a chronically injured joint or tendon, you see a joint that is chronically inflamed, which leads to swelling and pain. These kind of treatments, regenerative medicine treatments, can help to reduce that chronic inflammation. In addition, if you have neuromuscular health issues, which is very common in musculoskeletal conditions, we're able to actually help reduce irritation of those nerves, which then leads to a reduction in pain as well. And if you have spine or back issues, we can actually help to improve stability, which then leads to less pressure on those nerves as well. Just going to take a quick look at some of the questions in the chat. I see that some people originally had some issues with audio video. Hopefully that's been corrected. If not, please let me know. Somebody's asked about if you have an autoimmune condition, can these treatments help? And it depends on the situation. So I always feel like you should always take a look to see if somebody has an overall condition that could be causing problems. And if so, how do you treat that? In some cases, you do need to actually need to use medications or supplements to help reduce that overall inflammation. But in cases where that overall inflammation is better, but there's one or two joints that are still problematic, these kind of treatments can be very helpful. Regenerative medicine treatments can be very helpful to actually manage those kind of conditions. Another question asked about counting the number of cells that we're re-injecting. So one of the key things you need to be doing with these kind of treatments there are definitely best practices. There are ways to do regenerative medicine correctly and ways to do it not ideally. And one of the keys are for every patient that's being treated is to make sure you're actually aware of the number of cells that you're injecting. Important because we know that number of cells make a difference in terms of outcome. And we also know that there are ways to actually optimize the number of cells that you obtain. And if you're able to do that, you give somebody a better chance of actually getting a better result. So counting cells is important and certainly something that should be done by any physician that's doing this. So as I mentioned, my journey in regenerative medicine, originally I got interested in platelet rich plasma and prolotherapy for arthritis and tendinitis back in 2008. As I got more and more experience with that and more connected with other physicians who were using these kind of treatments, eventually I ended up joining the Regenetics Network and started incorporating bone marrow aspirate concentrate derived stem cells into my practice, and then progressively including other products as well, whether that's amniotic cells for tendon treatments or even utilizing adipose or fat cells as an adjunct for tendon and joint treatments as well. Some regenerative medicine basics. Number one, are these treatments legal? So there are very strict guidelines from the FDA. And those guidelines include, are you using your own cells? Number two, are you using cells that have not been significantly altered or adjusted? And number three, are you injecting them into orthopedic tissue as opposed to other tissues? So if you're following those guidelines, then utilizing your own blood platelets or bone marrow cells are legally compliant based on FDA guidance. Number two, if I'm older, a question I get asked frequently, if I'm older, should I be using someone else's cells? And the answer is no. So for most orthopedic conditions, there is good evidence that using your own live cells is appropriate and the correct thing to do. And the reason for that is because, number one, if you're using somebody else's live cells, there's actually additional risks that need to be thought about, including rejecting that person's cells. And in fact, it's considered illegal to actually inject someone else's live cells into yourself, the exception being certain childhood leukemias. So you should definitely be using your own cells because the evidence is there. Your body is prepped and finely attuned to accepting your own cells. And even from a safety standpoint and regulatory standpoint, based on rules from the FDA, you can only be using your own cells. Is there an age limit? Answer is no for the most part. The results for knees, lower back, shoulders, other joints as well are not impacted by age. With that said, hip outcomes are worse if you're older, over the age of 60. But for other areas, we don't think there's any effect of age. There are certainly potential issues if you have other medical problems, including if you have things like really bad diabetes, if you have very active inflammatory conditions, or if you have cancer as well, active cancer. But age itself is not a limitation. What sort of doctor does these kind of treatments? I strongly recommend working with a physician who's focused on what your problem is. So for regenerative medicine, for orthopedic use, it's someone who's really focused on musculoskeletal conditions. Reality is, if you're not focused, medicine is so vast, if you're not focused on what you're treating, you're not going to be getting expert care. You're going to be missing small, fine details. Number two, it should be someone who's focused on non-surgical treatments for orthopedic conditions. I think that's important because if you see someone who's focused on surgery, their focus is on surgery. That's what their expertise is in. That's where they add value. That's different than a non-surgical approach where you look at things a little bit differently and it leads to a different approach to how you treat people as well. And I think someone should be a proper regenerative medicine expert, which I'll talk about in a moment, because there are some fine things that you can tell if someone is really focused on this properly. Another question I frequently get is, can these treatments help if I've already had surgery? And it depends, but yes. If you've had, let's say, knee arthroscopy or rotator cuff repair or prior spine surgery, these treatments can still help. There's some exceptions would be if you've had, let's say, a joint that's been replaced where now you've just got hardware sitting there. That's a different kind of scenario. I wouldn't recommend injecting cells into that. But there are some exceptions where somebody's joint has been replaced, but they have some chronic back pain that's causing their leg pains now, that can still be treated. I think general rules I give to patients for orthopedic surgeries is, if possible, keep your anatomy. Once you cut something out, you can't really reverse that. Try to avoid surgeries that are strictly cutting out tissue as opposed to actually repairing tissue. And if you've been recommended surgery, always consider whether regenerative medicine treatment could be a treatment option to actually replace that. So I'll talk a little bit about what makes a regenerative medicine expert. And there's really three key things: stability or prolotherapy, orthobiologics, and interventional orthopedics. So stability is incredibly important when it comes to the musculoskeletal system. When you think about how the body functions, there's layers and layers of tissue around each joint in each area. And there's this concept of biotensegrity. This comes from the world of architecture. Tensegrity and biotensegrity is an extension of this in terms of medicine. Tensegrity means that if you take a structure under compression, the whole structure is stronger than the individual units are on their own. That's important because when you take something like a knee, the number of structures that are involved in terms of offering support there are quite a few. Everything from the skin, myofascial tissue, fascial tissue, muscle, tendons, ligaments, meniscus, then eventually the cartilage, the joint, and the bone. There's quite a few different structures that involve, and really treating each layer and level of that depth will give you a better response to treatment than if you're only treating, let's say, one layer of tissue. So someone who has, let's say, joint arthritis and pain, if you're only injecting cells into the joint and you're not treating all those other tissues, they're not going to do as well because their problem is that entire functional unit, not just the joint. That's painful. So how does that work? So prolotherapy is a process where you're injecting cells or other types of solution into ligaments, tendons, and muscles to strengthen the supportive structures. That leads to inflammation, a normal inflammation process, which then leads to a proliferation of cells and eventually remodeling of tissue. That whole process, once you start, it can actually take 6 to 12 months. By using orthobiologics, which I'll talk about in a moment, including using your own cells, you can actually get a stronger proliferative response. But it's all built on that concept of stability and prolotherapy. So prolotherapy is key because there's layers and depth of treatment to these kinds of conditions. And by treating the whole functional unit, you're strengthening and supporting tissues longer term. That leads to progressive strengthening over time and longer lasting results as well. So this is a case study of someone who had lower back pain, 71-year-old man who had a prior laminectomy surgery for his lower back. He's actually had 2 surgeries. Areas that we treated with platelets in his case included the ligaments of the lower back, the facet joints, the muscles, and the epidural space. His initial treatment gave him roughly about a 30% improvement in pain. We ended up escalating to bone marrow stem cell treatment, and that got him up to a 75% improvement in pain. And that's actually persisted for the last 3 years now. So keys to understand: a regenerative medicine specialist, someone who's really into this properly. They understand that these kind of treatments take time, that there's a slow progressive improvement. It's an understanding of prolotherapy concepts, which means that you need to treat multiple areas in each individual person, and that it can take multiple treatments over several months to get an ideal response. And understanding that you shouldn't be offering treatments that damage tissue, but rather you're focused on treatments that are meant to actually optimize and repair tissue. Someone who's maybe not as well versed in these kind of treatments may be looking at outcomes in a short-term manner, meaning they're looking to see if somebody's better in the first couple of weeks, not understanding that treatment responses can take a few months. In addition, they may be only focusing on one area. For example, I frequently see people where I saw a patient recently who, a young man who'd had a shoulder injury and had a PRP injection just into the joint, not understanding that really his problem is multi-issues in the shoulder and you have to treat all those areas. And so he hadn't really had an ideal treatment previously. And then frequently, another sign that maybe someone's not quite understanding of how these treatments work is that they may be first line offering you treatments, more traditional treatments like steroid injections and radiofrequency blocks that are really more short-term in nature and have risk of actually damaging tissue, instead of recommending first-line regenerative medicine treatments. See a question somebody asks about what are the risks involved in treatment. I'll get into that in a little bit. How do you compare risks of regenerative medicine versus risks of traditional treatments? But understand that with any kind of injection treatment, there's a low but potential risk when you insert a needle into the body of infection, tissue damage, and bleeding. You minimize those risks by utilizing standard sterility protocols to reduce your risks of infection, by using image guidance, including X-ray and ultrasound, to make sure you're hitting the right structures and not hitting anything you don't want to be hitting. And then lastly, by picking the right candidates, meaning some people are not the right candidates or maybe higher risk or not people who are going to get better. And you want to pick the right candidates, people who have a good chance of getting a good response and who are still low risk. Orthobiologics. Orthobiologics are essentially biologic cells and tissues that we inject into damaged orthopedic tissue. Again, this utilizes a normal healing process. There's always this issue of, do you use your own cells or someone else's cells? I mentioned before that there are risks when you use somebody else's cells in terms of rejection risk. And in the United States, really the only legally compliant cells to inject are using your own cells. There are products out there that come from other people, but they are dead cells. So they are legally compliant in that regard and they're lower risk. But I'll talk a little bit about why that doesn't make as much sense. So platelets. Platelet rich plasma, essentially after an injury, platelets recruit other cells and growth factors to assist in repair. You're utilizing inflammation to help repair damaged tissue. Platelet rich plasma and platelet-derived growth factors help to stimulate your local stem cells, which is how they work. They work by stimulating and bringing other cells into an injured area. How do you create platelet-rich plasma? Essentially, you do a blood draw, just a routine blood draw. You then go through a couple different layers of centrifugation in the lab, where we then isolate the cells that we want to concentrate those cells. On the right, you'll see two different types of platelet-rich plasma. There's red, sort of bloody platelet-rich plasma, and then on the left side, there's platelets without the red blood cells. As much as possible, when you're getting platelet-rich plasma treatment, you want to have platelets that isolate or get rid of the red blood cells. And so the platelet-rich plasma that has that yellow color is more just a concentration of platelets. That's what you want to use. A higher concentration of that is better for joints and as well as tendons, and a lower concentration we utilize for ligaments. Understand that for each individual person, there's not a one-size-fits-all approach. So for example, if somebody has a rotator cuff injury, you're going to be using a kind of a mid-size or a medium grade concentration of platelets, as opposed to, let's say, someone with shoulder arthritis, where you're usually using a higher concentration of platelets. You have to personalize that based on the person. There isn't like a one-size-fits-all approach. Frequently, this is done as a one-size-fits-all approach, and that's not correct. You're better off doing this in a personalized approach to your actual problem. Again, platelet-rich plasma, higher concentration of platelets are better for joints, tendons, and ligaments. It is more inflammatory, but that's the right way to treat these areas. Platelet lysate is another type of platelet product that we frequently use. Essentially, you take your platelets, you crack them open, and you just take the growth factors from that. Better for nerves, better for ligaments, and it's just less inflammatory. This is a case study of a gentleman who had platelet-rich plasma. He's a 45-year-old man that is a cyclist. He originally presented with left knee pain. On his exam, ultrasound and MRI, he's got patellar tendinitis. He'd been treated by his sports medicine physician, but wasn't getting better, and was referred to me after he had continued pain despite physical therapy. On the right side is an example of what patellar tendinitis looks like under ultrasound. This is your patellar tendon here. This is the bone, the patella. And this is an example of where the patellar tendon is swollen and pathologic. These are some osteophytes, enthesophytes or bone spurs within the tendon itself. So in this gentleman's case, he had platelet-rich plasma 2 times. That treatment got him back to his full capacity, back to cycling. To give you an example of what that looked like, again, this is his patellar tendon. This is a needle injecting cells directly into that tendon. Important because we're injecting directly into just a tissue that's damaged. In this individual's case, he actually presented 3 years later, at which time he'd now had an injury to his hamstring tendon. Again, he had platelet-rich plasma treatment, and he was able to get back to his normal activity level and get rid of his pain. So, regenerative medicine. Again, how do you know you're dealing with someone who knows what they're doing here? Number one, they understand the difference between the different types of platelets, platelet-rich plasma and platelet lysate. In particular, when they use high concentration platelets and when they use low concentration platelets. Question that was just put into the chat was, do we use leukocyte-rich or poor platelet-rich plasma? The keys are traditional leukocyte-rich platelet-rich plasma has a higher concentration of platelets, but has more red blood cells. And so what you want to actually do is use a high concentration of platelets, but minimize the amount of leukocytes or white blood cells and red blood cells. So there are ways where you can actually get the best of both worlds, meaning you can get a high concentration of platelets, but isolate out the white blood cells and red blood cells. So a proper regenerative medicine expert should understand those kind of differences. They should be able to personalize that treatment based on your condition, and they should be able to adjust or alter your platelet-rich plasma treatment based on your actual issue. Someone who's maybe not as much of an expert would be using the same platelet-rich plasma regardless of your condition, does not understand the difference between bloody PRP versus no blood PRP, and does not have flexibility in actually personalizing your treatment regimen. Okay, so the next type of orthobiologic I want to talk about are stem cells. So these are the main cell line, mesenchymal stem cells that help to drive tissue repair and recovery after an injury. You can use your own cells, or theoretically, you can use somebody else's cells. In other parts of the world, they use other people's cells. Again, in the United States, you can only use your own cells. The most common type of stem cell that we utilize or stem cell prep that we utilize in the United States is called bone marrow concentrate. That means cells that are coming from your bone marrow. That is the only type of live stem cell treatment that is currently legally allowed in the United States. You can get stem cells from your own adipose as well, but the enzyme that you utilize for that is not approved for human use by the FDA. And so fat stem cell treatments are considered not legal currently in the United States. You can use fat and adipose cells for structural support, but you have to be careful with how that is prepped and to remain legally compliant. There are other types of products that you may be hearing about, including amniotic and umbilical cells. You have to understand that there are no live cells there. So the way that those products are utilized in the United States and considered to be legally compliant by the FDA is that after baby is born, the amniotic or umbilical cord tissue is harvested. Those tissues are then pulverized and actually gamma radiated and created into a powdered form. That process essentially kills off all the cells. That is then shipped to the physician's office. Those cells are then rehydrated with water, sterile water. 3 different organizations have looked at, are there any live cells at that point when you've gone through that process? And the answer is there are minimal to no live cells. All you have are growth factors. These products can be helpful as an adjunct to a platelet-rich plasma or bone marrow treatment, but on their own, they are not a live stem cell treatment. IV stem cells are something that you may hear about. There's really no proven benefit for orthopedic conditions. There may be some benefit for lung issues or some other autoimmune conditions, but for orthopedic conditions, which is what we're talking about here, there's really no proven benefit for arthritis, tendinitis, injuries, or back pain. Stem cell treatment outcomes. Our goals more than anything else are patient-centric, and what that means, improving pain and function. And that can occur even in advanced cases. Why can that happen? So a couple of ways. Number one is you can reduce chronic inflammation. Chronic inflammation is really what drives a lot of pain in people that have chronic arthritis or tendinitis. In addition, stability is a key part of this, and we can improve stability. And that's why you can take someone that has a chronically arthritic joint, and by improving inflammation and stability, they can actually have pain relief and functional improvement. In addition, when you take a look at a joint that's been damaged, the cells in that joint or tendon or ligament or nerve tissue, they're not functioning well. You can actually get those cells to start functioning better by re-exposing them to your own healthy platelets or by giving them a booster of your own bone marrow stem cells. And lastly, when you're able to improve somebody's pain, you get them to be able to do more physical activity. That physical activity helps with muscle strengthening, as well as balance and proprioception. All of that leads to better strength and support of that treated area, which then puts you into a better cycle. That better cycle then leads to better strength, better support, better function, which then leads to less pain. Can you actually improve X-ray or MRI images? If you've got advanced arthritis, no, you're not going to be able to do that. If you have a tendon tear, and I'll show you some examples of that, that's small tendon tear, yes, you can improve that. Ligament tears can get better. I'll show you an example of that. If you have swelling in the bone, which you can see frequently in arthritic joints, that can actually get better. That's a dynamic thing that can actually get better in someone who has arthritis. And if you have a early to mid stage of what's called avascular necrosis, which is damage or tissue death in the bone, that can actually get better as well. But you have to catch that at an early stage. Can we treat bone-on-bone arthritis? So short answer is yes, and I'll explain how. There's this really terrible colloquial term that some physicians use, which is bone-on-bone arthritis. And it's to indicate that somebody has advanced arthritis. And the problem is that it gives people the wrong idea of what's really going on. When I think of bone-on-bone, I would think that range of motion is not possible. So if you have advanced arthritis in the knee, and your physician has called it bone-on-bone, but you still can push your knee through a normal range of motion, flexion and extension, you don't really have bone-on-bone. What you have is advanced arthritis. But you need to understand that arthritis is not a picture or just a structural issue. It's a biologic condition. And what that means is that you have functional issues, you have inflammatory issues, you have neurologic issues. And again, my take is that if your range of motion is still reasonably intact, and you can still get a good amount of pain relief and functional improvement, even if you have quote unquote bone-on-bone arthritis. there are some caveats. Again, if you've got advanced hip arthritis, the evidence is that that is a very challenging condition to treat. And hip surgery may be more appropriate at that case, in that time. I think if your expectations are based on pain and functional improvement, I think you can still get a very good result. If your focus is more on improving imaging, then that is not necessarily as realistic. Actually, I'll answer a couple of questions where people just asked me about that. Somebody asked, can bone marrow changes on imaging right after trauma improve? It's an interesting thing. If you have trauma, you'll find bone marrow changes that are temporarily there for a couple of weeks and that'll resolve on their own. But when you see bone marrow changes in more advanced arthritis, not from like recent trauma, but just more chronic arthritis, you can actually treat those changes in the bone and actually get that to improve on imaging. Again, the goal there is more about treating pain and inflammation and function, but you can actually get those changes to improve on imaging as well. Another question asked about, if we're talking mainly about osteoarthritis, does this work for rheumatoid arthritis? You know, as a rheumatologist, I kind of see it from a little bit more nuanced view than maybe some of my colleagues do. My take is that if you have really severely active rheumatoid arthritis, there's a lot of good treatments, traditional treatments that we utilize medication-wise to treat that overall inflammation that I would recommend first line. I can tell you that when you treat RA patients, that a lot of them still have chronic pain issues. And I think these treatments work really well in those cases, because whether that is a little bit of residual chronic inflammation from their RA, or whether that is some now osteoarthritis, those kind of conditions are very amenable to bone marrow or platelet treatments. And I do recommend that for my RA patients in that case. But if you have really flagrantly severely active RA, where you have 20 plus joints that are active, I wouldn't recommend these treatments first line. I would recommend first treating the overall inflammation before jumping into these kind of treatments. I hope that explains that. So here's, can tendon and ligament injuries can they actually improve? And this is an example of a knee ACL case. And so if you have a partial thickness injury to a tendon or ligament, definitely that can still improve. If you have a full thickness tear, depends on how bad it is. So this is an example of a 28-year-old man, young man, playing recreational volleyball. He had an ACL tear. I saw him about 2 months after his injury, and we utilized bone marrow concentrate stem cells. At the 3-month mark, he had no pain, and he had restarted dynamic exercise. But what's very cool is that he had very significant improvement in his imaging as well. The image on the right is an X-ray image of his procedure. I'll actually describe that a little bit more coming forward. So again, this is his pre-treatment MRI on the left, and that's his post-treatment MRI. So pre-treatment MRI, this is the femur bone, this is the tibia, this is the kneecap. The ACL is here. Now, you may be looking at that and saying, that looks very hazy. I don't have a good look of it. Well, that's what an ACL injury is. And this is considered a full thickness tear right in this location. And you can still see that there's still edges of the ligament that are intact, but they're not fully connected here. So this is 3 months after his treatment. And what you see is this is a normal looking ACL at this point. Very linear fibers, it's intact. There's still a little bit of fluid around there, but this is a pretty normal looking ACL for the most part. And that was a really great result of treatment in his case. And actually the treatment that we did, just to give you a sense of how that worked, on his X-ray imaging, so this is that ACL. We've injected contrast into it. This is the needle going into there. You can really only inject into an ACL under very high level X-ray imaging guidance, but great example of where you can get great treatment results with these kind of treatments if you're utilizing good technique, the right cells, and good imaging technique. This is an example of a gentleman that had A rotator cuff tear, 57-year-old man. He'd actually had a chronic tear that progressively gotten worse. The pictures on the left were his pre-treatment, and the pictures on the right are after treatment. So he'd had bone marrow stem cells as well as platelet rich plasma injected. And this is an ultrasound image of his rotator cuff tear. That is a full thickness tear. Now, the gap here is about 2 centimeters. This is, again, another view of that. But that is a full thickness tear. And this is 3 months after treatment. And he really was much better off. He had dramatically less pain, better activity. He's a contractor. He's able to get back to work. And this is what that tear looks like now. That tissue has started to fill in. You no longer see that gap. And that's, again, a really great result in someone who had a significant tear of their rotator cuff. Now, understand that if that tear was fully blown out where the tendon's not even close to the bone, I would have recommended him for surgery. But even in that case, actually injecting his own cells post-surgery would have been helpful. But in this case, this is someone who had a really great result after treatment. So again, proper regenerative medicine expert should understand the legal compliance about what is legally allowed in this country. There are physicians who over the last few years have been doing things that the FDA has not really considered to be legitimate. And now the FDA is starting to come down on them. So understanding the legal compliant treatments are important. Utilizing all orthobiologic treatments in a safe and honest manner, meaning giving you a realistic expectation, and appropriately determining your candidacy of treatment. Are you a good candidate or poor candidate? Someone who's maybe not as well experienced in these kind of treatments might not understand that amniotic and umbilical cord products available in the United States are not really real stem cell treatments because there's no live cells. They're not using proven protocols, and they don't have proven results. Interventional orthopedics is the idea of utilizing X-ray, ultrasound, and other image guidance techniques to finally, to really specifically treat your condition. The picture on the left is a rotator cuff, and injecting into a rotator cuff, and this is the needle using ultrasound guidance. Picture on the right, again, this is another shoulder, and this is a needle injecting into the joint. This black outline is actually proof that you're in the joint, and it's actually treating the labrum as well. And again, being able to do this under X-ray and ultrasound guidance is how you can make sure that cells are delivered at that sub-millimeter level. You can't do this blindly without image guidance. You're just guessing at that point. But you're able to inject very deep, precise structures that are damaged with these kind of treatments. These pictures I'd shown before as well. On the left side is a patellar tendon injection. On the right side is an ACL injection. This is an example of a avascular necrosis treatment. A 41-year-old man, he's a chef. He'd had osteoarthritis and chronic inflammation, but he also had avascular necrosis. On the picture on the left, this is what avascular necrosis looks like. It's basically lighting up in the bone. Luckily, he did not have significant breakdown of the bone, but he had definitely avascular necrosis. He'd had a bone marrow stem cell protocol treatment. 3 months later, when you look at it again, that signal is resolved. His pain is 90% improved. He's actually, I think, 4 years out now, and he's still doing great. Chef, he's on his feet all the time, and he's actually back to work and doing great. So again, regenerative medicine experts need to understand that when you're injecting orthobiologics, you are doing this under high-level image guidance. If your physician is doing this blindly, meaning just based on feel and experience, they're not hitting the exact tissue correctly. To be hitting very precise structures, you have to be using ultrasound and X-ray guidance. I think a proper expert in this is constantly improving their technical skills. What you're doing 5 years ago should be ancient history compared to what you're doing now. And you should be tracking your results in a formal registry, which we certainly do as well. If you're doing this blindly, you're just hoping and guessing. As I tell patients, until I have X-ray vision, I am definitely using the X-rays and ultrasounds that we have available to make sure we're doing this properly. I'm not Superman. And if you're not tracking your results, you don't know if you're doing things correctly. Regenerative medicine treatments offer safe and effective solutions for your pain. Okay, I'm going to get to a couple of these questions. Can you inject more than one location at a time? Yeah, it depends on what the problem is. The keys are you want to make sure you have enough cells. So that means if you have to take too much blood or bone marrow, you want to make sure it's safe for patients who are under treatment. They may need more than one treatment to cover multiple areas. But if they have multiple areas that need to be treated, we can frequently do that at one time as well. Another question about osteochondritis dissecans. Someone who had that as an adolescent, now they're a young adult, and they have some issues. Possible. It depends on how much damage there is and what the condition is in the person. For any condition, when we talk about it, the caveat is always, yes, we can treat that, but we need to know that individual's actual presentation and case to see if that's appropriate. And if it is, then we may be able to help them out. So is this too good to be true? I'll talk about that. So there's data for these treatments that goes back for some time now. I mean, these treatments are considered new, and regenerative medicine a new and burgeoning field. That's accurate, but the reality is we have data that goes back quite a ways. Philip Hernigue, physician from France, has data for BMAC, bone marrow concentrate, for knees and shoulders that goes back to the mid-1990s. Another question, the Regenix network, which I'm part of, has data that goes back to 2005. So these treatments are new, but if you've been in the field and if you've been experienced to do this for over a decade, you'll understand that they're not brand new. They've been around, and we have some pretty good experience. This is a rapidly developing field, but not new. And my own personal experience goes back to 2008. There are right ways and wrong ways to do this. I think as long as you're doing things the right way and you're giving people reasonable expectations based in reality and evidence-based medicine, these treatments are appropriate. Someone asked a good question. Is there a difference in terms of how men and women respond to treatment? No, absolutely not. Each individual person is going to be different, and gender does not make a difference in terms of expectations of treatment. How long do results last? So again, from the Regenix database, the Interventional Orthopedics Foundation database has data that goes over 10 years now. Data from Philip Hernigue from France has data that goes over 20 years now. What I tell people is have conservative expectations, meaning if you have a chronic condition that's been around for years, expect that you'll get good treatment for several years, but that you may need a repeat booster treatment at some point, maybe a few years down the line or sometime down the line. What we know is that repeat exposure to cells gives people a stair-step improvement, meaning the normal sort of process of treatment, let's say normal steroid injection, the way treatment results are, you may get an improvement and then sort of you come back down to baseline quickly. Regenerative medicine treatments, you're going to have a slow improvement over time, and you'll stay at that level. If you get a repeat treatment, it typically gives a stair-step higher response and gets you to a higher level. Best ways to maintain results after treatment: improve your biomechanics, work with physical therapy, a trainer, optimize what you can on your own, take the appropriate supplements, do everything you can from a lifestyle standpoint, whether it's supplements, exercise, diet, to optimize your health. And understand, again, that repeating treatment is additive to that initial treatment as well. Cost. Cost is always a big question that people have. Understand that these treatments, while evaluation is covered by insurance, these treatments are not routinely covered by insurance. There are some exceptions to that. Regenix has a corporate plan where quite a few self-insured companies, which frankly are most large companies, are self-insured, but a number of them have these treatments now covered and added to their benefits plan. You can learn more about that at regenixcorporate.com. If you work for one of these kind of larger companies that is self-insured, worthwhile having a conversation to see if Regenix Corporate can set something up with your human resources department. From a government insurance standpoint, Medicare does not cover these treatments currently. Your traditional Blue Cross, United Healthcare, Aetna does not currently cover these treatments. There is one government insurance that covers this, and that is TRICARE, which is the insurance for military, for active duty military. They do cover these treatments. So eventually more and more insurances will start to cover. Some cost estimates I've listed below for prolotherapy, platelet rich plasma, and bone marrow stem cell treatments. That's what you can expect to find sort of across the country. I think the keys to determine value in terms of treatment as a patient or as a consumer are, number one, make sure the physician, the clinic that you're working with are really regenerative medicine experts, that they know what they're doing, that they're giving you a real stem cell treatment, not sort of replacing your own live cells with maybe dead cells like amniotic fluid, and making sure that these treatments are done in the hospital, are done in the office. They don't need to be done in a hospital or surgery center. Your facility fees that come from a hospital or surgery center will spike up the cost of treatment, and you can avoid that because most of these treatments can be done in an office setting. So again, I think the right way to approach these treatments are having a focus that's non-surgical, focus on musculoskeletal care, focusing on inflammation, stability, symmetry, neuromuscular issues, starting with conservative treatments, escalating to more interventional treatments as required if you're failing conservative treatments, using the best quality products, being an expert in these kind of fields, and tailoring your treatment to what your issues are, and delivering cells using the highest level of image guidance. See a couple more questions coming in. What's a downtime or recovery process? Great question. Depends on what's being treated. So what I tell everyone is, after these kind of treatments, expect the first 2 to 3 days afterwards, more inflammation. So you'll want to be relatively low impact for those first 2 to 3 days. You can do your normal activities, but it'll be lower impact. Number two is you'll have stiffness for the first week or two after treatment, and then there's slow progressive improvement. I generally tell people expect, if you're doing, let's say, platelet rich plasma treatment, expect anywhere from 1 to 3 treatments over that first 1 year. If it's bone marrow treatment, expect 1 treatment and see where you are 6, 12 months down the line. The keys for these kind of treatments are expect a slow improvement. And your physician should have the approach that, how are you doing at 2 to 3 months? As long as you're still improving, you continue to watch. If you start to plateau and you haven't hit your goal, and that goal should be your goal, meaning are you reaching your pain improvement level? Are you doing the activities that you want? If you're at your goal, fantastic, then just continue to follow it. If you're not at your goal, considering repeat treatment would be appropriate at that point. Key kind of core principles that we have in my clinic are leading with integrity, respectful and collaborative care, transparency regarding candidacy for treatment and costs involved in treatment. Somebody asked about some of the costs that I had mentioned. That should be including your physician fees as well. Again, if it's done in a hospital setting or surgery center, there may be additional facility fees, but those costs that I mentioned really should be everything involved in terms of treatment. I think when you're working with your physician, they should be offering you the best options available, not necessarily what is just most convenient in their sort of model of care, and always doing what's right for the patient. Number one, if you have additional questions, always feel free to ask now or email us afterwards. We're always available to answer questions. If you're interested in being evaluated, on your screen should be popping up a link where you can schedule if interested. And again, at any time, we can continue to answer questions. I see a few more questions coming up. Someone asked, if they're currently seeing an orthopedic doctor who's not offering treatment, what's the proper way for the current doctor to write a referral note to someone who does this treatment? It's an interesting thing. There is this idea that patients have that they always need a referral letter. Unless your insurance mandates that, meaning if you have an HMO, you really don't need a referral letter. Most physician offices or specialist offices should be okay to accept you as a new patient as long as you have a condition that they treat. So I think the main thing from a communication standpoint is if you've had other treatments from another physician is to get that communication, meaning, okay, individual X has pathology ABC, and here's the treatments that we've done. As long as the next specialist has access to those records, which should not be a problem, I don't think you really need anything more from a referral standpoint. Somebody asked about how successful are PRP and stem cell injections for a minor meniscus tear. There's more involved in that question than just what's being asked, because do you have a meniscus tear and you already have knee arthritis? If you already have knee arthritis, then your issue is not the meniscus tear. Your issue is that you have a degenerative process in the knee, in which case PRP or bone marrow stem cells can be very helpful. The other part of that question is, well, suppose you only have a meniscus tear but no other degenerative issues, let's say an acute tear. And it depends on what kind of tear, right? There's certain types of meniscus tears that probably should go to surgery first, and then you add on bone marrow on top of that. There's other types of tears that can still improve with PRP and stem cells on their own. I think the keys are on examination. How's your range of motion? Do you have any locking sensation? If you don't, then I think proceeding with these kind of treatments makes sense first line. If you have arthritis, it makes sense to proceed with bone marrow or PRP first line. On the other hand, if you have a meniscus tear that's catching, locking, you don't have arthritis in the knee, then surgery may make sense first line. What I would personally do, if that were my knee, is post-treatment surgery. If they repaired it, I would have them add bone marrow cells after that, whether that's from the surgeon or your regenerative medicine expert. But there is some evidence that adding bone marrow cells post-treatment can actually give better long-term results. Wonderful. I think I've answered most of everybody's questions. If not, please go ahead and type them in, or if after we're done, you can certainly email us afterwards, and we are available to help and assist, whether that's with questions, guidance, or treatment. We are here to assist. But I appreciate everyone's time. Afterwards, if you want to rewatch this, you will get an email that'll give you an opportunity to rewatch this as well. And until I guess we connect again, I hope everyone stays well and stay safe. Have a good day. Bye-bye.